Hi everyone. In this COVID-19 era, approach to a chest pain in the emergency room is drastically different from the non-COVID era. In this brief video, I will show you certain basic guidelines on how to manage chest pain in the emergency room. The Society of Cardiac Angiography in the last week of March 2020 has given a protocol for the management of chest pain in the COVID-19 era. Any patient presenting with chest pain in the emergency room has to be determined whether the patient has got an ST elevation myocardial infarction. If there is ST elevation myocardial infarction, it is highly recommended to perform primary angioplasty because it can be safe, faster, short hospital stay, and the chances of the person infecting the other people or contracting the infection from other people is lessened because the hospitalization stay is shorter with primary angioplasty. If the myocardial infarction is non-ST elevation myocardial infarction, then we must determine the COVID status before we go ahead and perform the procedure. We should perform an angiography and angioplasty if the patient is COVID negative only. If the patient is COVID positive, the preferential management is medical management. But in case if the patient has got high risk feature for non-ST elevation myocardial infarction, then we should do an angiography and angioplasty wearing full personal equipment guard. When a patient arrives with chest pain in the emergency room, we need to have certain protocols in place. The first step is the patient should be given a surgical mask lest he has a chance of infecting other people. All patients should be considered as COVID positive or potentially positive unless proven otherwise. We have to take an electrocardiogram and differentiate a STEMI from a non-STEMI. After the STEMI or non-STEMI diagnosis has been made, it is important for us to differentiate whether the myocardial infarction is a consequence of COVID. So we should always correlate the ECG findings with echocardiography, and the echo is showing wall motion abnormalities consistent with the regional changes of myocardial infarction on the ECG, then we can diagnose it as a type 1 myocardial infarction. But COVID majoritarily presents with a type 2 myocardial infarction where the troponin elevation is not very rapid and the regional wall motion abnormalities and the ECG changes usually do not correlate. Ideally, it is preferred to have a screening test like a nasopharyngeal swab by RT-PCR before we take this patient for coronary angiography and other procedures in the cath lab. But unfortunately, this test has got limited availability. So in the short of that, what I personally do is to perform a HRCT chest, but the recommendations for this by various professional societies is not very strong. But if the HRCT shows changes suggestive of COVID, then I do not take this patient for angiography and intervention. Very important point is if the patient is in respiratory distress, we need to avoid a high flow nasal cannula, ambu ventilation, non-invasive ventilation with CPAP or BiPAP because these procedures have a very high chance of producing aerosols. If intubation is required, we have to perform by using a rapid sequence intubation, and the use of a video laryngoscope is highly recommended. If the patient requires CPR and intubation, we should not be in a hurry to treat the patient, but we should shift the patient to an isolation room, and the CPR and intubation should be performed with minimal staff and all of them wearing full personal protective equipment. I hope This video will help you to quickly triage your patients in the emergency room. Thanks for watching.